Welcome back to United Dry Needle's YouTube channel. Today we're going to wrap up part 2 of the whole do trigger points exist argument. Some people feel really strongly that trigger points do exist. Some people feel really strongly that trigger points don't exist. Part 1 talked about kind of the arguments for and the arguments against. And then I kind of just left you hanging, didn't really give you the definitive. So part 2 is going to just roll with the argument that, okay, let's just say trigger points don't exist. Then what the heck else is happening when you stick a needle in something? So that's what we're going to talk about today. Appreciate you hanging out with us. Appreciate you watching United Dry Needling's YouTube channel. And if you would subscribe to the channel, you can click that link just right down there to subscribe. And hang on, should be a fun ride. Let's jump right into this. Are trigger points real? Are trigger points not real? That's the big question. So let's just do a quick reminder of what we talked about in the first video, part 1 of this Do Trigger Points Exist series. So if you remember some of the research that we saw that said trigger points don't exist, we had the Myberg article from 2008 that said there was poor reproducibility of manual palpation for trigger point identification, and the whole argument there is if you can't palpate a trigger point, then how can you stick a needle in a trigger point, right? You had another article by Lucas and the colleagues in 2009. Physical exam cannot currently be recommended as a reliable test of the diagnosis of trigger points. That's pretty strong. And then you had an article by Lewis in 1999 that compared a manual therapist touching a trigger point and then diagnostic ultrasound by a radiologist, and they found no correlation between the clinical identification of active myofascial trigger points and diagnostic ultrasound. And then you had the scathing argument by Quinter and colleagues in 2015 that basically said the theory of myofascial pain syndrome caused by trigger points has been completely refuted. And that would be one of the main articles that you see for people that say trigger points don't exist. And then remember we talked a little bit about Botox and what Botox can do to the whole neuromuscular junction. You had Cottle in 2018. Botox were injected into trigger points that caused the neuron to stop working as expected, but the pain and the symptoms of the trigger point did not disappear. And that's really interesting. So if you fix the trigger point, if you literally put the trigger point to sleep by depleting the acetylcholine and by inhibiting the neuromuscular junction with this Botox toxin, theoretically that should have made the trigger point pain disappear. It should have made the pain disappear if the trigger points disappeared. So maybe those symptoms weren't related to the trigger points in the first place. So maybe the whole idea is wrong here. And then when we talk about the arguments of the trigger points do exist, you had the Chen article in 2007. So magnetic resonance elastography, which is a really cool MRI that uses some other kind of little sound waves to determine how skin elasticity or tissue elasticity, how tight it is basically. That exam confirmed the existence of myofascial taut bands detected by manual palpation. So what the clinician felt, they run it through the MRI machine with this fancy elastography setting on the MRE machine, and what the person palpated was what the MRE found. And then you had Kojo Karu in 2015. They were looking at diagnostic ultrasound with thermography, so with temperature measurement. So trigger points were represented by higher temperature surrounded by a cooler area, probably caused by a deficit in the blood flow around those points. So potentially that's a little bit of proof for the energy crisis theory. And then you had that cool study by Shah in 2003. They did a microcatheter analysis of aspirated tissue in these areas of trigger points. They did active trigger points, they did latent trigger points, and they did a control, which was no trigger points. And when they analyzed that tissue, or when they analyzed that fluid, they found some tissue hypoxia, they found some inflammatory mediators, they found lowered pH, and all of that was evidence of acidity. So if you remember the energy crisis theory, that kind of perfectly aligns with the energy crisis theory, right? So maybe a little bit of proof there. And then you had the Rathbone and colleagues article in 2015, which was a rebuttal to the Quinter article, and they found themselves unable to agree with Quinter's assessment that all working hypotheses derived from the conjecture have been refuted, and therefore the theory can be discarded. That's what they have trouble believing. And what some of these authors quoted, reproducibility of detection of trigger points is not strictly confined to the skill of manual palpation. Remember, that's how they determined, that's what the literature used to refute trigger points when they were examining it, was manual palpation. These authors state that palpation, observation, and feedback all have to combine during your trigger point examination to influence the examiner judgment. And then none of the studies available in that systematic review consider these phenomena altogether, and they're prone to variability and error. So that's kind of one of the ways that Rathbone refuted how Quinter refuted the trigger points even existed. They were just like, well, what you're refuting your trigger point basis on is a little bit of, maybe flawed research, maybe just a little bit. And then when you look at Travell and Simons, literally decades of passionate work, right? Over 2,000 pages, this trigger point Bible, millions of copies sold. Still a best-selling book. People still use it. People still have to buy it in different programs in physical therapy, physical medicine rehab. People still buy these books. But let's just, for the sake of the argument, assume that everything in those manuals is wrong. Like all 2,000 pages of those manuals is wrong. So let's just make us an assumption, for the sake of argument, that trigger points do not exist. So in that case, if trigger points don't exist, then how is your dry needling effective? Why are you seeing good results when you stick a needle in a patient, even if trigger points don't exist? So just to kind of talk about that argument, let's find out what else is happening when you stick a needle in somebody. It's not just sticking a needle into a trigger point. It's sticking a needle into the skin, and some things happen. So let's talk about that and kind of see what's going on. When you think about some of the mechanisms that are at work when you stick a needle in somebody, regardless of whether a trigger point exists or not, something physiologically is happening within the patient's body when they get stuck with a needle. So when you look at what else is happening, we're going to look at this study by Chu in 2012, probable mechanisms of needling therapies for myofascial pain control. This was an evidence-based complementary and alternative medicine back in 2012. So the most likely mechanism of pain relief through needle stimulation is what they refer to as hyperstimulation analgesia, which is through stimulation of A delta, A beta, as well as C fibers, indirectly through the release of inflammatory mediators. So A delta and A beta fibers send afferent signals to the dorsolateral tracts and activate supraspinal and higher centers involved in pain processing. So that can happen when you stick a needle in somebody. Look at another study by Chu, 2002, the muscle twitch and myofascial pain relief, kind of the effects of acupuncture and other needling methods. When a needle is rapidly thrust into a trigger point, the local twitch response evoked leads to a large diameter sensory afferent proprioceptive input into the spinal cord. This could have what they refer to as a gate controlling effect on blocking the interdorsal horn passage of noxious information. And I know in a lot of our programs, whether that be physical therapy, occupational therapy, athletic training, you're familiar with the gate control mechanism, and that's one of the mechanisms behind maybe why electrical stimulation is effective when we talk about pain control. And then a 2007 study by Nidham and colleagues, central modulation of pain evoked from a myofascial trigger point, Clinical Journal of Pain. So using functional MRI, they discovered that pain following needle insertion and electrical stimulation is mediated through the periaqueductal gray in the brainstem. The periaqueductal gray is the central part of the opioid circuitry that controls the nociceptive transmission at the level of the spinal cord and the cortex. So a change in periaqueductal gray was associated with a change in pressure pain threshold. If you remember pressure pain threshold, that's where you take an algometer and you push it into the patient's skin. And if the pressure pain threshold is low, that means you push it into their skin and they're like, ow, that hurts, leave me alone. Then they have a very low pressure pain threshold, so then they have increased irritability, right? It's an inverse relationship. And if they have a very high pressure pain threshold, you take that algometer, you smash it into their skin, and they're like, that doesn't hurt at all, just keep pushing. Then obviously they have a high pressure pain threshold, which correlates with a low irritability. So change in periaqueductal gray was associated with a change in pressure pain threshold. Stimulation of nociceptive fibers may activate the encephalinergic inhibitory dorsal horn interneurons. I know those are all some big words, but it's kind of cool that when you stick a needle in somebody, that something is stimulated in the brain, and they were able to see that on a functional MRI. They were able to see that the periaqueductal gray was one of the areas that was modulated when you stuck a needle in somebody. So that's kind of cool. And then this is a study by Long in 2012. So stimulation of A delta nerve fibers may activate the serotonergic and the noradrenergic descending inhibitory systems, releasing the neurotransmitter serotonin and noradrenaline. So we know that can also be beneficial for pain relief and making the patient feel better. Even if a trigger point doesn't exist, when you stick a needle in somebody, you can release serotonin and you can release noradrenaline to kind of make the patient feel better. I think we would be completely remiss if we didn't talk about the idea of placebo analgesia, kind of in its role in the management of pain with a needle or with any kind of manual therapy technique that you do. So it's well known that expectation can significantly modulate pain perception. That mechanism is frequently referred to as placebo analgesia. Neuroimaging data demonstrates that placebo analgesia recruits subcortical and opioid-sensitive brain regions that are also involved in pain perceptions, such as the periaqueductal gray, the thalamus, the insula, the amygdala, and the prefrontal cortex. Many of those areas overlap with the areas modulated by needling. They used to tell us in the Army that false motivation is still a sense of motivation, right? So placebo analgesia is still analgesia. And I really think you have to talk about that and think about that. If you have a patient that comes in, they've had a pain in between their shoulder blades. They've had that pain literally for like 6 months. It's been driving them crazy. They come in, they lay on your table, you palpate that area. They're like, oh my gosh, that's the spot that hurts so freaking bad. And then you're like, okay, fool, I'm about to heal you. And then you wipe them down with alcohol, and then you grab your needle and you stick a needle in the spot that hurts so freaking bad. You're literally getting inside the spot where they hurt. In a manner that you can do with a needle so much more than you can do with your hands, and even putting your elbow in it and stuff. The patient is going to perceive that you've done more because you stuck a needle in the spot that hurts so much more than if you just touched it. So clearly they're going to have a little bit of an expectation that that's going to probably make them feel better, right? So I think that rolls in with placebo analgesia. But again, just like they told us in the Army, false motivation is still motivation. So placebo analgesia is maybe still analgesia. And then Weiner, 2016, reports that palpation skills are difficult, if not impossible, to measure. Therefore, as is often the case, research is lagging behind clinical experience and anecdotal evidence. Just going to kind of talk about the bottom line, try to wrap this up a little bit. Physical therapists have been treating trigger points for a long time, lots of years with needles. We've treated trigger points even before we were sticking needles in them. We were treating trigger points with our hands, with sticking our elbows in them, with doing ischemic pressure on them, with scraping them, doing grassing, whatever, with your butter knife. We've treated dysfunctional spots in the muscle for a long time. Can we reliably palpate a trigger point? That's really going to just depend on what side of the argument are on. Some people think that you absolutely can palpate a trigger point. Some people think that the idea of trigger points is dumb. You couldn't palpate them even if they were there. Maybe the literature is steering us away from the reliable palpation argument and maybe pointing us a little bit more towards the chemical and the centrally mediated theories of muscle dysfunction. But honestly, I find it a little bit hard to believe that any clinician with even a moderately developed sense of touch would argue that trigger points don't exist. The idea of trigger points makes sense to patients, it makes sense to clinicians, and honestly, it's a way that we've practiced for a little while. And then when you think about specifically the literature that we looked at that said trigger points don't exist, or basically that you can't reliably find a trigger point, that was only 2 systematic reviews, and it was that Manual Therapist versus a Radiologist article, and it was the Scathing article by Quinter and colleagues. You just have to wonder if that could outweigh the decades of research that have been done by Travell and Simons, and then all the other people that have researched trigger points. You just have to wonder if that's enough to just definitively say that, okay, trigger points don't exist. This whole idea is dumb. Let's just not do it anymore, right? But maybe that is enough. Maybe a couple of systematic reviews and the good article by Quinter, maybe that is enough to refute that argument. I don't think it would be wrong to continue with the trigger point model until there was some significant, overwhelming evidence to the contrary. And if that does happen, even if some phenomenal, like grade 1A research comes out that the trigger points don't exist, okay, I'm okay with that. Okay, trigger points don't exist then. And then I just remember kind of everything else that happens when you stick a needle in somebody, right? All those cool things that we talked about. But it is important to understand both sides of the argument, and that's kind of how I want former students to understand, and even people that don't really know much about dry needling to understand that there is an argument out there, and that argument is it's just 2 sides. Some people really strongly believe that trigger points don't exist, and some people really strongly believe that trigger points do exist. To discount everything that Travell and Simon's done, though, I think that's taking it a little bit too far. And I'm not just like so hardcore that yes, trigger points exist. Yes, you palpate this area of the upper trap. Every time you'll find a trigger point out, you grab it, you bracket it, you stick a needle in it. I'm not that hardcore about that. I do feel stuff under the skin when patients have pain, and I rub around on that, and it may feel like a knot, it may feel like a band, it may feel like what I forever just thought was a trigger point. It may be a trigger point, it may not be a trigger point. I usually, when I work on it, when I do something to it, whether that be with my hands or whether that be with a needle, usually the patient feels better. But one of the things that I do feel pretty strongly about is some of the Travell and Simon pain referral patterns, when they injected these noxious substances into a muscle and then they gave the patient, a clipboard with a picture of the body on it, and they said, draw on this clipboard where this hurts you. That is stuff I've seen in the clinic. Like, I've seen gluteus minimus refer pain down the leg. I've seen the rectus abdominis, where do a little bit of pelvic floor rehab. I've seen the rectus abdominis refer pain into the testicles in a male. I do believe pain referral patterns, upper trap, ram horn, headache distribution, that crap is real, right? So I think it's a little hard to discount everything that Travell and Simons has done, but there's definitely a big argument about whether trigger points are the cause of it. But muscular pain referral patterns, I'm gonna have to stick with that one. I can't give that one up just yet. But bottom line, we'll see where the literature takes us. Right now, I'm still it's just up in the air. They don't exist. They do exist. They don't exist. They do exist. Like, it just depends on who you follow on social media and who is the loudest about it. When I teach dry needling courses, I give it just like this. I tell you both sides of the argument. You get to kind of keep an eye out on the research and develop that idea for yourself. Develop that what you're going to believe for yourself. Thank you for hanging out with us, United Dry Needling's YouTube channel. If you missed part 1, that video is a little bit longer, but you can catch that where we talk a little bit more about the trigger points don't exist versus do exist. And then thanks for watching this video that talks a little bit about what else is happening when you stick a needle in somebody, whether trigger points exist or not. Again, if you will, subscribe to the channel. I think it's like right down there, or maybe on this side. I'm not sure. But you can click that little red subscribe button, and then you can keep up with all our content. Thank y'all again, and I hope to see you in a course someday.